let's talk about clinical assessment. We can start with Jack. Jack is a 13-year-old boy who comes in with his mother. During the visit, we note that he's frequently scratching the flexural areas of his arms. He's had dry, itchy skin on his arms for many years, but in the past 2 years it has worsened considerably, and he notes that his symptoms are worse in the winter. His mother had asthma, and his father experiences seasonal allergies, and in fact, Jack has had asthma since 4 years of age. On examination, we note generally dry skin with erythema, dryness, and some lichenification in the flexural areas of both of his arms. And further examination shows hyperlinearity of his palms and some increased scaliness of his legs, in addition to involvement in his popliteal area. In fact, his mom, who's with him, also shows hyperlinear palms and tells me that throughout the winter she's putting lots of moisturizers on her legs because they're so dry.
Let's talk a little bit about how we assess a patient who comes to the office with what we think may be atopic dermatitis. Obviously, it's very important to get a good history in terms of itching. How persistent is the itching? Does the itching involve daytime activities as well as sleep? How does the itching and scratching impact the patient's daily activities and sleep? And how long has this been occurring, or how long has the duration of this disease been noticed? We also ask about, because this is atopic dermatitis, and it helps us to at least categorize this condition, is to know what the family or personal history of atopy is. We ask the patients whether they've had seasonal symptoms during pollen seasons, or they're allergic to dust or indoor allergens. We also get a good family allergic history. We ask about symptoms, early symptoms of asthma, which may be coming to the fore and actually follow the onset of atopic dermatitis. Is there any history of a food allergy, particularly milk and eggs in early years of life? Again, we ask about sleep disturbance, and we also try and probe to see whether there have been any issues with adjustment disorders or mood disorders, looking for signs of depression. What we don't recommend generally is using scales to actually measure severity in routine clinical practice. These really should be reserved for clinical trials and studies. We also explore the history for evidence of risk factors that may predispose our patient to develop atopic dermatitis. We already mentioned the family history of atopy, which is very important. If you have two parents, for instance, with an atopic history, your chance of developing atopic dermatitis is 3 to 5-fold higher. We also are aware that there are certain genetic mutations in the filigran gene, which was already mentioned, that would be significant risk factors for more severe persistent atopic dermatitis that has earlier onset of the disease. But this only really involves a minority of all patients, perhaps 10% or less. And these patients may also be more predisposed to develop herpes, eczema, herpeticum, or herpetic infection of the skin. There's only a moderate association with race, a slightly higher association in African Americans, and there seems to be a signal that patients with parents of higher education status may have a greater risk. We don't have any clear evidence that exposure to indoor pets or urban living environments or daycare environments predispose to development of atopic dermatitis.
There was an interesting study that I just want to mention that came out of Ireland, where they're prospectively analyzing a broad group of children without any increased risk of having atopy or atopic dermatitis. And in prospectively analyzing these children, they looked at transepidermal water loss, which is a great functional measure of how well the epidermal barrier is working. And they measured this at 2 days as well as at 2 months and 6 months of age, and followed these babies to see if they would develop atopic dermatitis. And what they found is that those babies that were in the top quartile in their transepidermal water loss at 2 days of age were more than 7-fold more likely to have atopic dermatitis at 1 year of age. And in fact, they've now followed this group of patients out for a longer period of time and find similarly that those that had the greatest transepidermal water loss at 2 days of age had a higher risk of developing food allergy at 2 years of age. So some very interesting data really reinforcing the importance of that very early barrier function with the risk of developing atopy. And what's interesting is that actually this transepidermal water loss at 2 days of age was not dependent, for example, on having a decrease in filaggrin because of a filaggrin mutation, so wasn't reflective of that, but does raise the question to us of whether we can seize this information for a way to intervene and maybe prevent the development of atopic dermatitis, perhaps the atopic march. And in fact, there have been 2 studies recently, one out of the US and the UK, and the other from Japan, that have shown us that if in the first weeks of life one starts a daily emollient in those children at higher risk, that is, there's a first-degree relative with atopy, there is a decrease in the risk of atopic dermatitis. In the study from Simpson and Williams from the US and the UK, for example, that was a decreased risk at 6 months of age by 50% by just starting in the first 3 weeks of life the use of a daily emollient.
So that sounds like a great idea for a large primary prevention study in the future.
And in fact, they're doing that right now.
Well, let's talk about some of the essential diagnostic features of atopic dermatitis. We know that, of course, pruritus is the most predominant feature that really brings the patients to see us most of the time. We look at the skin and we see this eczematous dermatitis. We can see differences in whether these are acute or subacute or chronic lesions which have secondary changes. The typical, though, morphological patterns we look for may vary with age. We know that in infants and children we generally will see, more likely to see, skin involvement in the face and the neck and the extensor areas. At any age we might see flexural lesions or changes. And we generally will see sparing of the groin and axillary regions in patients with atopic dermatitis. And of course, this is a chronic condition. It can come and go. It can get worse and better depending on certain factors. But it is also important that we, again, recognize that this is an early age of onset. This occurs primarily in young children. And that atopy is a very important factor that we need to document in our history. And of course, dry skin is almost a universal feature we see in all affected patients, both adult and children.
So you mentioned the differences in the appearance and distribution of the skin based on age. Just want to spend a little more time mentioning that because that's important to recognize. So when we see babies who are affected, we see a lot of facial involvement, particularly on the cheeks and the chin, and of course that becomes exacerbated by the fact that as they start teething and they're drooling a lot, that saliva is a tremendous irritant and probably is contributing to the fact that we see that distribution at that age. We also can see so much swelling and oozing in association with the tremendous inflammation that's going on the face that it can be mistaken for infection when in fact it's just that exuberant inflammatory response. Babies can have involvement of the scalp. In fact, it's common to see an overlap of seborrheic dermatitis or cradle cap and atopic dermatitis at that age. There's often quite a bit of truncal involvement then too. As we evolve into the age of toddlers and even towards the end of that early infant age, we tend to see more involvement on the extensor surfaces. I've always thought that may relate to the friction of crawling, for example. But we tend then to see, as these children then get towards school age and adolescence and adulthood, really more of what we typically think of as the distribution in those flexural areas. particularly the antecubital areas and the popliteal areas. We think of the neck involvement. We can see facial involvement, but that facial involvement really tends to be more periorificial, around the eyes, around the mouth, not so much the cheeks and chin that we saw in babies. And of course, once babies get out of diapers, and that diaper area is a spared area, one of the good signs early on of atopic dermatitis is that sparing of the diaper area, we can see really the entire body being affected at that point. Let me also mention two other very common features of atopic dermatitis in children in particular. One is keratosis pilaris, that is the plugged hair follicles that we commonly will see on the lateral aspects of the face and the extensor upper arms and thighs. And the other is this association with ichthyosis vulgaris. You mentioned this earlier in talking about the filaggrin deficiency that's genetic. Almost 10% of, particularly those of Northern European or Asian descent, will have ichthyosis vulgaris from this deficiency of filaggrin, and that manifests with hyperlinear palms, so we see more lines on the palms, and also with drier skin, and particularly on the lower extremities, and particularly in colder weather. It can just disappear during the warmer weathers and when there's humidity. So keratosis pilaris, ichthyosis vulgaris, two other factors to look for in the examination.
Keratosis pilaris, is it an acneiform appearing lesion
Well,
sometime?
it can look like acne, but tends to be much drier.
Drier,
But it
yeah.
is a follicular process.
Yeah, okay, thank you.
Now, there are things to consider in the differential diagnosis for atopic dermatitis. I think we'd be remiss not to talk about that a little bit. And the first and most important of these are other eczematous disorders. We stressed before, not just calling this eczema, because that is a broader term. And some of these eczematous disorders can occur as differential diagnosis, but they also can occur concomitant with the typical atopic dermatitis. For example, seborrheic dermatitis, I mentioned earlier, can be seen particularly in babies on the scalp. Dyshydrotic eczema, seen on the hands and feet, sometimes just manifesting as what looks like severe atopic dermatitis, but sometimes also showing very tiny papular lesions, vesicular lesions. Sometimes it's been likened to tapioca pudding appearance on the palms and soles, sometimes lining the fingers and toes. Hand eczema in general, particularly on the palmar areas, although we so commonly will see irritant hand dermatitis on the dorsal aspect of the hands because of that exposure to cold weather and particularly to excessive hand washing. And then nummular dermatitis, those well-defined plaques of dermatitis, often with secondary infection, that can be scattered on the trunk and on the extremities in particular. We can't forget about contact dermatitis in the differential diagnosis. Contact dermatitis can be irritant, and of course these individuals with atopic dermatitis have very sensitive skin, are more easily irritated. We talked about that with saliva and the propensity towards having cheek and chin involvement in those young babies. But we can also see this with exposures to a variety of irritants. And then there's allergic contact dermatitis. And that's something that we can often suspect from distribution and then confirm with patch testing. But nevertheless, it's something that you have to think about because it can occur exactly in the areas of the atopic dermatitis if it's a response to something that's being applied topically to treat. Then there are other disorders in the differential diagnosis. Psoriasis, particularly in children, can be somewhat indistinct, can often be misdiagnosed as atopic dermatitis. Scabies, of course, when it occurs, causes a lot of scratching and can look eczematous, can be mistaken to be atopic dermatitis, or can be on top of atopic dermatitis and lead to exacerbation. And then more unusual disorders. For example, the infant with ichthyosis or an immune deficiency may present with an atopic dermatitis-like picture. Sometimes photosensitivity dermatoses. So the distribution will help with that. erythrodermas, where there's extensive redness and dryness everywhere from a variety of causes. And in adults with atopic dermatitis, we always need to think about cutaneous T-cell lymphoma,
Right.
very commonly misdiagnosed as atopic dermatitis, but is unresponsive to traditional therapy.
Well, we also need to think about how the laboratory can help us in evaluating our patients with atopic dermatitis. In general, we'd have to agree that laboratory testing is not needed for most patients. The serum total IgE is a strong marker of atopic dermatitis seen in the majority of patients. There have been numerous biomarkers that have been studied in many research studies, but at this time, none are really reliable to help us distinguish atopic dermatitis from other skin disorders you mentioned, for instance. Now, if you have a patient, though, with a strong atopic history that coincides or follows atopic dermatitis, it is important to consider respiratory allergies. There are some patients in whom their skin condition may actually aggravate during a pollen season, and you can get that from history. In that case, testing may be helpful. In terms of food allergens, generally to do this food allergy testing in all patients is not helpful, but if you have a good history suggestive of the skin getting worse after ingesting milk or eggs or some other food, this may certainly be worthwhile to test the patients for food allergy, either by serum-specific IgE or skin testing, if that's possible.
And of course, laboratory testing can be helpful in looking at the differential diagnosis for some of the conditions that
Right.
I mentioned. A biopsy of skin may be helpful
Absolutely.
in distinguishing those. Well, let's go back to Jack with his comorbid ichthyosis vulgaris and atopy.
Well, Jack has a strong family history of allergy and atopy. He's developed asthma. He developed a pretty significant case of atopic dermatitis, pretty severe, at a very early age. His parents also have a positive history of atopic dermatitis, and they had some of the manifestations that might even want us to consider ichthyosis vulgaris in the differential diagnosis of this family. And this, again, is the strongest genetic risk factor. We don't know if he has it or not, but it's something to at least think about. And we know that Jack follows that pattern of the atopic march. He's developed early onset atopic dermatitis. Now he has asthma, and we expect that his condition of asthma will persist as he gets older. Let's talk about management of Jack and patients like Jack in the upcoming management module.